I mean, all subjects combined to form medicines. You don't like renal?
No.
We'll do only wanted topics in renal, not
Okay. Okay.
because sir said no, it's on the number one.
Yeah.
Good evening to everyone and welcome to today's wonderful evening with Dr. Murli Bharadwaj. How can you revise the entire medicine within about 6 hours? In the last moments of the exam is all about. Let's start with acute MI. What are the earliest ECG changes between ST elevation, T wave inversion, hyperacute T waves, Q waves? It is the hyperacute T waves. T waves will be tall. How do you know whether it is any repolarization defect or whether it is due to MI? You look whether it is a symmetrical T wave or asymmetrical T wave. Based on that, you will basically decide.
So which is symmetrical?
That you need to check. Right?
Yeah.
So, the most specific enzyme of all enzymes is troponin T, which will peak in about 24 to 48 hours. Myoglobin is the earliest enzyme to get elevated. And how about CKMB? Typically, it will be normal within 72 hours. That's the reason. If you want to detect the reinfarction, the best enzyme is CKMB, but not the troponin. Now, if there is any posterior wall MI, how will you detect that? There are no posterior leads. You will see in the antral leads V1, V2, V3. Instead of ST elevation, you find the ST depression. Now, what is that anterior wall MI? Vessel. Left anterior descending. Left coronary artery divides into two branches. Left anterior descending and circumflex. Left circumflex. Then right coronary artery divides into posterior descending artery.
PDA.
So when do you call dominant circulation?
Descending artery is in left or right.
Right. So when do you call left dominant circulation? When the PID, when posterior descending artery, PDA, arise from left circumflex instead of from the right coronary artery. Then after the MI, there is a development of pericarditis with fever and effusion. What do you call it as? Dressler's syndrome. What is the most common cause of the death? Before reaching the hospital, it is the acute VF and VT is the most common. Similarly, in the hospital, most common cause of death is
Rupture.
it is the cardiogenic shock.
Shock.
Whenever the anterior wall MI is significantly affecting the pump function, that lead to cardiogenic shock. If you hear a holosystolic murmur, that is an indicative of severe mitral regurgitation, which can occur whenever the papillary muscle rupture is a complication of the acute MI. If there is a pansystolic murmur with a biventricular failure of both the right and left ventricle, it is an indication of ventricular septal rupture, which can occur because of the ischemic necrosis, is what we need to remember. Whenever LV free wall ruptures, it leads to tamponade, sudden cardiac death.
So symmetrical tall T waves is MI.
Correct. Symmetrical is MI. Because the tomb after you die with MI will be symmetrical. Easy to remember.
Yes.
Now, reperfusion. Whenever you reperfuse, there will be oxygen-free radicals, which lead to arrhythmia, which is called accelerated idioventricular rhythm in case of the MI. So what is TIMI score? Whenever you are stratifying a patient, what is his risk of developing non-STEMI or unstable angina to progress towards MI? TIMI score will help you, right? So what is non-STEMI? Non-ST elevation MI and unstable angina. In both of them, ST is not elevated, though there is a very severe ischemia. Then how do you differentiate? Non-STEMI is having elevated cardiac enzymes, but unstable angina does not have. That's the reason unstable angina is called pre-infarction angina, is what we need to remember. Then what is the criteria to call a STEMI? When the ST elevation is more than 1 mm in two contiguous leads, more than one, we need to remember. What is the preferred thrombolytic? Tenecteplase. What is the door to balloon time from heart attack to
PCI.
90 minutes. Putting percutaneous stent.
Intervention. PCI.
Contraindicated drug in MI is NSAIDs, except aspirin. What is the beta blocker? ACE inhibitors, beta blockers. What is their popularity in a patient with MI? Whenever a MI patient is getting discharged, you will invariably include the beta blocker and ACE inhibitor because the long-term morbidity and mortality.
Ventricular
It will help in remodeling of the heart is what we need to. One of these is going to be your question in MI. MI is sure short topic.
Yes.
అది లేకుండా పేపర్ లేదప్పా.
Yes.
ఒక వాటర్
Yes.
బాటిల్. Good to see three online classmates. Very good, doctor. బజర్ పెట్టే టైమర్ పెట్టు. ఎంతసేపట్లో ఒక టాపిక్ లేపుతాం. 122 టాపిక్లు ఎంతసేపట్లో. గంటల పంచాంగం అంటారు.
పెట్టాలా సార్?
So there are different layers of preparation. When exam is far away, you will go more detailed. 30 days before, you will have another set of points, 40, 50 points on each topic.
Bottles లేవు చెప్పేసి.
పర్లేదు. వాళ్ళు లేకుండా ఫోన్ చేసి చెప్పండి అబ్బాయి.
చెప్పు.
Now, the next topic, hypertension. Joint National Committee, JNC 8 has given criteria to diagnose BP. इसके पहले जमाने में 120/80 was criteria, but now 140/90. If the patient is more than 60, little more extra provision given, less than 150/90. The most common type is the primary hypertension, which typically happen after you cross the age of 40. There is no reason. When do you suspect secondary hypertension? When the age of the patient is less than 40 or more than 60. If it is less than 40, conditions like pheochromocytoma, renal artery stenosis, etc. Above 60, underlying cause is atherosclerosis, which lead to narrowing of the renal artery, leading to secondary hypertension. The most common cause of the secondary hypertension is chronic kidney disease, like people with diabetes, with diabetic nephropathy, typically will develop hypertension, most common cause. In a young, sweet-looking female developing hypertension, underlying cause is fibromuscular dysplasia of renal artery. What is the angiographic finding in that, doctor? There is a beaded appearance, like Rudrakshamala, is the classical feature. What is the best way to diagnose renal artery stenosis? Renal arteriography. Whenever hypertension with abdominal brie, think of renal artery stenosis. Hypertension with low potassium, Conn syndrome, primary hyperaldosteronism. Hypertension with episodic palpitations, pheochromocytoma. And what is the test for pheo? Metanephrines. Whenever there is any coarctation, narrowing of the aorta, then the blood flow to the lower limb will decrease. That's the reason radiofemoral delay will be there. And when coarctation, when there is a narrowing of aorta, there will be collaterals developing, which will be running through the intercostals. Intercostals are there in the rib, in the lower margin. That's the reason there is a rib notching along the lower margin of the ribs, classical of the coarctation of aorta. If there is any superior rib margin, rib notching, neurofibromatosis is the cause. Inferior rib notching, coarctation of aorta. When do you call hypertensive emergency, doctor? If it is more than 180/120 with an end organ damage, like the kidney, etc. When do you call urgency? Without end organ damage, more than 180/120. When do you call malignant hypertension? Hypertension with papilledema is malignant. What's the treatment of it? We give the calcium channel blocker like nicardipine or a alpha plus beta blocker like labetalol is the treatment of choice. In pregnancy, what is the drug of choice? Labetalol, methyl-dopa, nifedipine. Methyl-dopa very commonly we give. And whenever there is any pheochromocytoma, what do you give? Phenoxybenzamine. What is it?
Blocks.
Alpha blocker. Alpha blocker, right? What is the first line of treatment whenever a patient walks to your clinic with essential hypertension, 40 to 60 age group anukondi? We start with thiazide, hydrochlorothiazide, Telma H, contain 12.5 milligrams of hydrochlorothiazide. ACE inhibitor like telmisartan, ARB, and calcium channel blocker like nifedipine. Now hypertension plus BPH if they come. If you give alpha blocker like prazosin, alpha 1 blockade will relax the smooth muscle, leading to bladder outlet obstruction relief. So alpha blockers are preferable with BPH. If there is a hypertension plus diabetes, you have to introduce telmisartan and ARBs invariably. Hypertension plus CHF, 3 drugs, beta blocker, ACE inhibitor, diuretic should be there in his prescription. But if it is a decompensated congestive heart failure, stage 4, beta blocker, it is a contraindication, is what we need to know. Next comes the infective endocarditis. 4 minutes, one topic.
Right.
So, 15, 1 hour. 130, 10 hours.
Yeah.
డైరెక్ట్ గా వెళ్ళి కూర్చోవాలి ఇక్కడ, మళ్ళీ అక్కడ ప్రజెంట్ చేయాలి అంతే, ఇందులోంచి వస్తాయి.
Yeah.
Okay, now let us take second topic much faster. Very good to see 6, huh?
6.
Yeah.
6 online classmates. We are becoming very popular teacher. Huh? Good, doctor. Can you please punch me? Is the voice loud and clear, doctor? Now, infective endocarditis, most common valve, mitral valve. Only IV drug abusers flow through the vein, it will go to right side of the heart. So IV drug abusers, it is the tricuspid valve. Purushottama, ni peru unde? Raju. Now, the most common organism leading to infective endocarditis is Streptococcus viridans. But if there is any prosthetic valve placement, within first 60 days, if it come, it is called early infective endocarditis, Streptococcus viridans. More than 60 days it is Streptococcus viridans, but less than 60 days it is epidermidis. Whenever acute infective endocarditis is there, most commonly it is Staphylococcus aureus. Whereas overall most common organs is viridans. ఎందుకంటే viridans lead to subacute bacterial endocarditis. Acute is Staph aureus, subacute is viridans, but most common is subacute. Overall, అందుకోసం viridans. Culture negative organisms are HESEC, Haemophilus, Acinetobacter, Kinganella, Kingae and Echinella corrodens, Foxiella, Bartonella. ये सबको याद रखना. Osler snorts, Janeway lesion. Osler is painful raised finger nodule, painful os, cervical os in PID.
Yeah.
Janeway is painless in palm and sole, and it is a macule, not a nodule. Rot spots are the retinal hemorrhages with a pale center. And what are the Duke's major criteria? Positive blood culture plus eco-vegetation. Minor criteria: fever, predisposition, vascular phenomena, immunological phenomena, the rot spots,
Yes.
culture.
Okay.
Best initial test is blood cultures, 3 sets. Most sensitive test is transesophageal echo that can detect the smallest vegetations. Whenever native valve is involved, not a prosthetic valve, vancomycin plus ceftriaxone. Prosthetic valve, vancomycin plus gentamicin plus rifampin. Then what is the indication for surgery? Whenever there is a CHF, uncontrolled infection and emboli. The most common complication of infective endocarditis is heart failure, and certain procedures which are entering into your gut or urologically invading, they are all high risk. Similarly, between ASD, VSD is a high risk lesion for getting infective endocarditis, not the ASD. PDA is a high risk lesion because it is also very high pressure zone where the blood is flowing. So High-risk lesions, when there is a dental procedure or genitourinary or endoscopic procedure, we do prophylaxis. And we give amoxicillin 2 gram 1 hour before the procedure is a indication. 3 minutes mein khatam. I think I'll be also a formula raiser. Viraj brother is a top formula raiser.
I googled yesterday. I didn't know till then.
Is it?
I didn't know yesterday when he told me. I googled.
Shortly you Google about me, I'll be found as a popular teacher of Viraj. Now comes the heart sounds. Start. S1, mitral tricuspid closure. S2, aortic and pulmonary valve closure. S1 typically has got a high, it is heard at apex. And it is heard
High
typically with the diaphragm. S1 and S2. S3, S4 are heard with the bell because they have a high amplitude, low frequency. So S2 is heard in the left second intercostal space. Left
Second.
second intercostal space is the S2. Left second la emuntadandi? Pulmonic area untadi. Right second is aortic area. Now, wide split second heart sound. That means P2 is delayed. That's the reason A to P2 gap increased. When there is a right bundle branch block, left bundle has to finish its job and then go and supply the right side. That's the reason the pulmonic valve closure become delayed. If there is a pulmonary hypertension, pulmonic valve take a long time to push the blood into that hypertensive pulmonary artery. That's the reason wide split. Just in exam hall, imagine A2 first, P2 second. Is the A2 getting early, then widening? P2 getting delayed, widening. Can you give me one condition where A2 can get early? Suppose if there is any VSD. When the left ventricle is contracting, all the blood is moving into
Right ventricle.
A2 to the ventricle to left ventricle to right. So very little blood is available to push into aorta. So aortic valve closes earlier. That lead to widening of the split. Simple logic. Okay? This is mala batti kottakodu. Fixed S2. That means A2 and P2 are separated widely. But at the time of inspiration, there is no further widening. Is the feature of ASD. Enduku, normally during inspiration, what happens? Negative intrathoracic pressure will suck during inspiration the more blood and pours into the right atrium. But ASD में क्या हो गया? Already left atrial blood came into right atrium through ASD. It will say, "Nahi Baba, no more extra blood during inspiration." That's the reason it is, but still it is widened.
Yes.
Why? Because there is more blood. Left atrial blood also is coming into the right atrium. And all that extra blood is going across the pulmonic valve. So pulmonic valve got delayed. But it won't further delay beyond the inspiration is called fixed wide split in ASD. What is paradoxical split? When the RBBB causes A to P2 gap widen, LBBB will cause left aortic closure so delayed that it comes closer to
P2.
the P2 and it will, in fact, P2 will come first.
First.
Any aortic stenosis also can cause A2 delayed that it will come after P2. That's the reason pulmonary hypertension cause RBBB by delaying the pulmonic valve closure. Aortic stenosis will lead to LBBB. I mean, sorry, not RBBB. Sorry.
LBBB is paradoxical.
Pulmonary hypertension will cause the pulmonic valve got so delayed, it lead to wide
Split.
S2. Aortic stenosis will cause aortic valve closure so delayed that it lead to paradoxical S2. S3 is a sign of rapid ventricular filling. You know, the filling of the ventricle from atria, that means ventricular diastole, has 3 1/3. First 1/3 is because of atrium is fully pregnant with blood. No contraction, last 1/3. That's the reason atrial fibrillation la last 1/3 undadu. Contract the atria. First 1/3. Atrium is full with blood, the valve opened, and then the atrium pours into the ventricle. That is first one third. Second one third, atria is at higher level than ventricle. Newton's first law said that apple falls by gravity. It will. Last one third, atrium contracts and pushes the blood into the ventricle. That is the last one third. So when there is a first one third rapid ventricular filling, if there is any ventricular failure, earlier systole may, it is unable to pump the blood into the aorta fully. LV failure. And it will be stagnant in the
Atrium.
right. Ventricle is unable to push the blood into the aorta because of the failure. So it is already having a pool into which the rapid filling is occurring during the first one third of diastole. That lead to the sound which is called third heart sound. So third heart sound is the feature of congestive heart failure. Congestive heart failure. Pregnancy, the amount of blood is increased, no? So all that blood is not pumped by the heart. And that rapid filling of more blood also can cause S3 sound. Agreed?
Yes.
But the time when it occurs is during the rapid ventricular filling phase, which is the first one third of the ventricular diastole. Clear? Then S4. Whenever a person is having hypertension, ventricle is hypertrophied, it is non-elastic to extend. During that time, last one third of the last
one third of the ventricular diastole.
Oh. What happened?
Just share, sir. It's still live.
Huh?
Share your screens.
Okay. Sorry. ఎక్కడున్నా మనం షేర్ స్క్రీన్ ఓకే
Share screens.
స్క్రీన్ ఎగిరిపోయిందా
Sir.
పవర్ ఉందా ఉందిగా
Yeah.
ఇదేనా
అదే సార్.
ఇది కాదు కదా I need to come out of this view. ఇదేనా
ఇదే సార్ లేఅవుట్.
Okay. Got it right?
Yes.
So, అదండి cause.
S4.
Okay. So, S4 ki cause enti? Whenever it is a stiff ventricle because of hypertrophy, like left ventricular hypertrophy in the people who are having hypertension, or if there is any hypertrophic obstructive cardiomyopathy, or whenever there is any myocardial infarction, post-MI, the heart can undergo remodeling and it become non-elastic. And that can also lead to stiffness, leading to S4. Mainga, S3, CHF, S4, LVH. You don't know. Then ejection click, where do you listen? Whenever there is any bicuspid aortic valve or aortic stenosis, we hear ejection click when the valve opens at the time of systole. Opening snap is a hallmark of mitral stenosis. Mid-diastolic rumble is the hallmark of mid-diastolic. Lub, dub, drrr, lub, dub, drrr. Whenever there's any mitral stenosis,
Okay.
when the atrial blood is walking into the ventricle, The stenotic valve will lead to mid-diastolic murmur.
Yeah.
Lap, dap, drrr. Mid-diastolic murmur is a feature of
Mitral stenosis.
stenosis. Early diastolic murmur is the feature of
Aortic regurgitation.
regurgitation. And ejection systolic murmur is a feature of
Aortic
stenosis. Pansystolic murmur, zzz, zzz, kind of a sound.
Yeah.
Throughout the systole.
VSD. No. Mitral.
Pansystolic is seen in VSD, but mitral regurgitation.
Yeah.
Mitral regurgitation. So, ఇప్పుడు ఎన్ని తెలుసు మీకు కామన్ థింగ్స్ ఆస్క్డ్ ఇన్ ఎగ్జామ్?
5.
Mitral regurgitation.
మైట్రల్ స్టెనోసిస్ లో ఏముంటుంది?
Mitral stenosis.
Mid-diastolic.
Mid-diastolic
Mid-diastolic.
Rumble, murmur.
Early systolic.
Early diastolic murmur,
That's in
AR.
AR.
yeah. And ejection systolic murmur,
AS.
AS.
yes. And pansystolic murmur,
MS and
MS,
VSD.
MR
MR,
MR.
and VSD.
MR and VSD. And Austin Flint murmur,
It's in AS.
AS.
hey, AR.
Oh.
AR లో ఏమవుతుందంటే when the flow coming from the regurgitant jet, when will regurgitation occur? Aortic regurgitation. Ventricle ఏం చేసింది? It did systole and pushed the blood into aorta.
Yeah.
Then it is undergoing diastole.
Yeah.
That time this regurgitant stream is coming. And the same time from left atrium into left ventricle, the
Stream.
Yeah.
forward stream is coming.
Yeah.
The both clash.
Okay.
And that lead to Austin Flint
Flint.
murmur. So Austin Flint murmur is also a mid-diastolic murmur,
Yeah.
which is seen in
AR.
aortic regurgitation. But what is the difference? How do you differentiate between that and mitral stenosis? Mitral stenosis murmur has got a opening snap.
Okay.
Mitral stenosis called mid-diastolic murmur has an opening snap, which is not there for Austin Flint. Opening snap ఎందుకు ఉంటుంది? Because the tight mitral valve.
Stenosis.
అది ఉంది కదా aortic regurgitation లో.
Yes.
Yeah.
Second, the one more differentiator, presystolic accentuation.
Oh.
Mid-diastolic murmur last 1/3 లో ఏమైతుంది? mitral stenosis లో atrium contract అవుతుంది.
Increase.
I push చేసేప్పటికి lub-dub, it will say. So it is presystolic accentuation is the feature of mid-diastolic murmur of mitral stenosis, but not Austin Flint. At least for example, Austin Flint అనేది
AR.
AR అని గుర్తుపెట్టుకుంటే జీవితము ధన్యమవును.
AS.
A-
Graham Steele.
Graham Steele is seen in pulmonary regurgitation. ఇది దీనిది దాంది అయిపోయి మస్తు మోర్ దెన్ ఎనఫ్. మాకు ఇవన్నీ గిట్లేం తెలియదు. మేము ఎంట్రన్స్ రాసినప్పుడు పెద్ద తోపులేం ఏం కాదు. ఎండీలో అది కూడా ఫైనల్ ఇయర్లో ఎగ్జామ్ కేసరి నేర్చుకున్నాం అంతే. సో డాక్టర్ tell me, systolic click is a feature of mitral valve prolapse. Mitral valve prolapse. So what is common between hypertrophic obstructive cardiomyopathy and mitral valve prolapse? రెండిట్లో కూడా
Loud.
systolic murmur ఉంటుంది. But whenever anything that makes the size of the ventricle smaller will cause worsening of the systolic murmur.
Okay. Hypertrophy.
Like, for example, you are standing, there's a decreased venous return. That will decrease the preload to heart. Ventricle size becomes smaller, and that will lead to mitral valve prolapse murmur. And I think a smaller chamber will prolapse easily, no?
Hypertrophy.
అట్లనే hypertrophic obstructive cardiomyopathyలో mitral valve and interventricular septum టచ్ అవుతాయి కదా. మరి ఇవన్నీ కష్టపడి నేర్చుకున్నాం
అవును sir. Yeah.
అపోలోలో.
Yeah,
పొద్దున్నే
good.
లేచి
Yeah.
క్రికెట్ మ్యాచ్ ఉన్నా we did
Yeah.
sacrifices.
Yeah.
So, and just retouching them
Yeah.
is everything.
Yeah.
Atrial myxoma will impede, just like mitral stenosis. Atrial myxoma is most common in the left atrium. So tumor plop will be there. Constrictive pericarditis will lead to pericardial knock. Then early diastolic plop is the feature of atrial myxoma. Now what conditions will increase S1, a loud S1? Anything that shortens the PR interval and mitral stenosis. Diminished S1, anything that
Cancer.
prolongs PR interval and mitral regurgitation, and calcified valves also will
Calcified
become
valves.
soft. S1 will not be loud. Where do you find single S2? Whenever there is any TOF. Why in tetralogy of Fallot there is a pulmonic stenosis? Such a severe pulmonic stenosis that pulmonic sound is not heard at all. Right? Then Eisenmenger syndrome is what? Pulmonary hypertension significantly. That also will make the pulmonic sound not heard. Then whenever there is any severe aortic stenosis, aortic sound will be so loud that you can't listen the pulmonic sound. So all these four, severe AS, severe PS in TOF or Eisenmenger, all the three are the causes of the single S2 is what we need to remember. Right? So next topic, Doctor. Coarctation of aorta. ఎంతసేపు అయిపోయింది?
30 minutes.
30 నా? ఓ మ్యామ్. సో ఇవన్నీ గుర్తుంటాయా? ఇవే అడుగుతాడు. మీరు ఇంత ఫాస్ట్ గా చదవాలి ఆప్థల్మాలజీ అన్ని కూడా. 6 pages, half an hour, 12 pages, 1 hour, 50 pages, 4 hours. బా మెడిసిన్ 4 hours లో కథం చేసినట్టే ఈజ్ ఎ మ్యాన్ విత్ బాల్స్. లాస్ట్ మూమెంట్ బిఫోర్ ఎగ్జామ్ అంటే ఇవన్నీ ఏంటంటే మినిమం గ్యారంటీ. ఇవి తెలిస్తే మిగతా ఆన్సర్ చేయొచ్చు అట్లా. ఇప్పుడు ఎప్పుడు సండేనా? ఈ సండే కాక నెక్స్ట్ సాటర్డే. We'll give a 2-minute voice break. 2 కల్లా వచ్చేస్తా. I'll try to come by 2 o'clock. I finish hospital early.
Okay.
In 5-6 days, I'll try to what you call dumma marenge hospital.
సో మీరు 6 to 8 వచ్చినా పర్ఫెక్ట్ ఉంటుంది.
ఒక 2 hours నేను వస్తే మీరు మిగతా చదువుకోగలుగుతారా ఫాస్ట్ గా అనేది క్వశ్చన్.
మేము ఫస్ట్ చదువుకుంటాం.
నేను 6 hours చెప్తే మీకు ఫాస్ట్ అవుతుందా?
వద్దు. లేదు సార్, last minute we need to read our stuff.
But her stuff is taking less time.
Yeah, for medicine, good.
Yeah.
Other subjects.
Ophthalmology also. We'll keep a bet.
So I need to revise by myself.
Okay. Let's see first. Let's finish the medicine. Medicine itself is a
Huge chunk.
huge. Now, if you look at the coarctation of aorta, what are the 20 points? The most common site where the narrowing of the aorta occur is after the origin of the left subclavian artery. Right? Then you have what? Patent ductus arteriosus. Ductus arteriosus, which connects the aorta with pulmonary artery.
Yeah.
Preductal, postductal.
Yes.
That's how you divide. Often the coarctation that you see in the aorta is in the infants is before the duct connection between the aorta and pulmonary artery. Preductal. It is more severe, right? And it generally will be associated with the patent ductus arteries, which is required.
Yeah.
Right? Whereas adult type అయితే ఏమైతుంది, asymptomatic ఉంటారు, ductus arteriosus తర్వాత వస్తుంది narrowing. అది గుర్తుపెట్టుకోండి ఇది. The most common type is adult, which is postductal. Turner syndrome and coarctation. Upper BP is more than lower BP. ఎందుకంటే మీ అయోటా నారో అయిన తర్వాత లోయర్ limb will not. Then radiofemoral delay, where delayed femoral compared to radial pulse. Bilateral rib notching will be there. On X-ray, what do you see? Before the narrowing, there is a pre-coarctation dilatation of aorta. Post-coarctation dilatation. Together, they look like a figure of 3.
Okay. Yes.
On chest X-ray.
Okay. Yes.
Similarly, esophagus is
Indentation.
posterior mediastinum, and also aorta, which is pre-coarctation dilated, is also posterior mediastinal. So it will, if you pass barium into the esophagus, then there will be an indentation which is called E sign, opposite to 3 sign. With Vetcon. Infant presents with CHF, it is more severe because it is preductal.
Yes.
Yeah.
So CHF with weak femoral pulses. Adults, they present with hypertension, headache, and claudication. Then the other day I've seen in the vascular center where I practice, he came for claudication. Everyone thought maybe it is peripheral vascular disease, but he has got hypertension, headache, young person, and on evaluation found to have narrowing. So the best initial test is echocardiography. Most sensitive is MRI angiography. Gold standard is conventional angiography. What is meant by gold standard?
I mean,
It is the gold standard.
yeah.
Marriage day is a gold standard, but that is the day we fight. Valentine Day is the gold standard of romance. We can be romantic any day, but on Valentine Day, definitely we will fight and break up. Maximum breakups happen on Valentine Day. So other than now, preoperatively, before you are repairing that narrowing, you need to control hypertension with beta blockers. So what is the surgical indication? Any gradient across that narrowing more than 20 millimeters of mercury means it is a severe coarctation. And after repair, there can be an aneurysm, hypertension, re-coarctation, anything is possible. And often coarctation can be associated with the bicuspid aortic valve. So Turner syndrome, bicuspid aortic valve, don't forget. And how do you screen in newborn baby? You do pulse oximetry and BP in all 4 limbs, so that a lower BP in the lower limbs is an indication of presence of coarctation. Clear? 3 minutes. Very good. అన్ని 4 నిమిషాలు లో వైద్య శాస్త్రం లో నిపుణులు. Rheumatic heart disease. And ఇవన్నీ you expect one question on coarctation, one heart sounds అట్లా వస్తాయి రేపు exam లో. Most common valve involved in rheumatic heart disease is mitral valve. Most common lesion is mitral stenosis. Pathognomonic is Ashkoff body in myocardium. And what are Ashkoff body cells? And Tishkoff cells, which are looking like caterpillar, classical. What are the Jones major and minor? Carditis, polyarthritis, chorea, erythema marginatum, and nodules. Minor, fever, arthralgia, raised ESR, and prolonged PR. And what is the supporting evidence? Raised ASO, anti-DNase B antibodies. Most specific of all the features is hidden hand. There will be no carditis, no arthritis, no subcutaneous nodules, but only chorea can be there. What is chorea? Purposeless
Dancing.
writhing movement. Purposeless dancing like movement like the discotheque in Saturdays. Now, the most common feature of the ARF is of all migratory polyarthritis. Most common. Most specific and Sydenham chorea. Adunte inkem lekunda kuda rheumatic fever. Earliest is arthritis, carditis.
Okay.
Mudane ikkada. Polyarthritis, migratory polyarthritis. Either pehla, either baad mein, either baad mein. Then most specific is Sydenham chorea.
Also most
Earliest to come is carditis.
most longest is also chorea.
Obviously. Last to stay.
Hmm.
Which type of hypersensitivity? There, the streptococcal antigens, our antibodies against that, will crossfire on the myocardium. The M protein of the beta hemolytic streptococci, antibodies produced against that, will interact with
Myocardium.
our myocardium. And what type of endocarditis will be found in rheumatic heart disease? Sterile verrucous vegetations. Verrucae ante like grouped nodules. Sterile, they don't have any infection. Infective organisms emundu dantla, unlike infective endocarditis. Pericarditis is fibrinous, bread and butter pericarditis it is called as. And whenever there is any chronic rheumatic heart disease, the commissures of the valve get fused, and when you are doing 2D echo, it looks like a fish mouth appearance is classical. MS murmur mid diastolic rumble, MR murmur pansystolic murmur, AR murmur is early diastolic murmur. And what are the prophylaxis? Benzathine, penicillin G, IM. And secondary prophylaxis, until how long you need to give? 5 to 10 years or till the age of 21 to 40.
Whichever is longest.
Whichever is earlier.
Longest.
Longest.
Earlier కాదు సార్ whichever ఎంత
Or
ఎక్కువ
till age of 21. Anyway, 5 to 10 years or till age 21 to 40 గుర్తుపెట్టుకోండి. Most common cause of MSC is rheumatic heart disease. Most common cause of the death in rheumatic heart disease is heart failure is what we need to remember. Right? Good. Can the online students can punch? Is the voice loud and clear? Now, doctor. Cardiac tamponade. What is tamponade? There's a lot of fluid around the heart which is causing the compression of the ventricle during diastole. That's the reason. What is the hallmark of cardiac tamponade?
diastolic collapse.
Diastolic collapse of the right ventricle. If you can document it on 2D echo, then you call tamponade, not just the presence of the fluid around the heart. So what is the backstrat? Because the ventricle is undergoing collapse, it can't pump out the blood. That leads to hypotension. Because the ventricle is getting collapsed, right ventricle, jugular vein cannot drain JVP raised, and all the fluid will prevent your stethoscope from listening. So muffled heart sounds. So what is the most common cause leading to pericardial tamponade? Malignancy, lymphomas, etc. They metastasize to the pericardium, leading to pericardial effusion, which will be rapidly developing, leading to the development of pericardial tamponade. More than malignancy, after malignancy, trauma, and any infective pericarditis, like Coxsackie virus pericarditis, etc. Then, pulsus paradoxus. Normally, only systolic BP will fall during inspiration by negative intrathoracic pressure.
Yeah.
will cause more blood sucked into right side of the heart, which will lead to more blood into right ventricle, which will cause interventricular septum to press against the left ventricle, and the left ventricle output will diminish. But what happens in cardiac tamponade? All the fluid around the heart will exaggerate this, and there is more fall of the BP, cardiac output, that you can't feel the pulse, but the heart is still beating. That's the paradox about the pulses paradoxes, right? Then what is Kusumal sign? Typically, Kusumal sign means whenever there is any constrictive pericarditis, the jugular vein at the time of inspiration is supposed to empty into the right atrium more, but it doesn't happen. So lack of the inspirational collapse of the jugular vein and jugular vein remaining prominent during inspiration. A farmer is walking into your OPD. He has got a prominent jugular vein not collapsing during inspiration. He also has an ascites. Everybody is thinking maybe TB, maybe TB. But you removed the collar and checked prominent. Then what is the cause? Cardiac constrictive pericarditis, often due to TB. And why ascites is there for him? Because the portal vein drains into the liver. The liver will drain into the hepatic vein. Hepatic vein drains into the IVC. IVC drains into the right atrium. If the IVC cannot drain into the right atrium, there is an increased pressure in IVC leading to increased pressure in the hepatic vein, leading to the development of portal hypertension. Ascites. Portal hypertension occur undali before coming to liver. Either liver ke baad mein
Extra
hepatic vein, extra hepatic vein. Portal vein into beta. Portal vein is formed by two veins. What are they?
Your
Supermesenteric vein
and inferior,
splenic vein.
superior and
Splenic vein. Gurjana? Mesenteric vein, splenic vein combine to form portal vein, which drains into the liver, and that forms hepatic sinus that combines to form portal hepatic vein that drains into the IVC. Only lobe of the liver which does not drain into hepatic vein but rather directly into IVCs is the gold medal. That's the reason hepatic vein thrombosis unnappudu adi hypertrophy aitadi. A lobe of the liver, quadrate lobe, caudate lobe.
caudate.
But-Chiari syndrome, hepatic vein thrombosis, caudate lobe hypertrophy is an indicator of hepatic vein thrombosis. Okay. Right? So, this is the Kusumal.
Yes.
The Kusumal will be there in constant. And the Kusum ascites social. And the liver drains into hepatic vein, into IVC, into right heart, which doesn't happen in constrictive pericarditis. Clear? I know what doubt is lingering in your mind. But cardiac tamponade, sir?
No.
Drainage problem.
Yeah.
JVP.
Jugular vein into this.
Yeah.
More problem is from right atrium into right ventricle. Is more.
And damp. Yeah.
So electrical alternance means the QRS complex will be small, big, small, big, small, big. Because of the waving fluid will cause the amplitude altered. This is easy to low voltage QRS. Overall, all QRS complexes will be small in voltage. Best way to look at the test tamponade is echo, where you can see the RV diastolic collapse. Gold standard is catheterize the right heart. Then you can know the pressures inside the chambers of the heart. Right? Then what do you see in JVP?
Right.
The Y descent is because of what? When the atrial blood is filling into the ventricle, the atrial pressure will fall down, which lead to Y descent in JVP. And that will be blunted, absent, because atrium is unable to fill into the ventricle, is very classical. Yeah. The most specific sign is right atrial collapse on 2D echo. And another important feature, when you do catheterization of the heart, because of all the fluid around, there is a equal diastolic pressures in all the 4 chambers of the heart is characteristic feature. Right? So the right atrial pressure, the right ventricular pressure, pulmonary artery pressure, right?
Yeah.
Pulmonary artery pressure and pulmonary capillary wedge pressure, which is indicator of left, they will all be equal, which is known through right heart catheterization. The most emergent treatment of cardiac tamponade is remove the fluid around the heart pericardial synthesis. Preferred site, sub-xiphoid approach. Xiphoid process ఉంటుంది కదా ఇక్కడ దాని కింద నుంచి. Right? So why there is a tachycardia in tamponade? Because cardiac output is not happening. Because filling is decreased. Hence, there is a tachycardia. And what is the role of fluid therapy? If you, in this situation, if you happen to administer the fluids, then you are increasing the preload so that inside the chamber pressure you are increasing, it will overcome the outside chamber pressure. And the question, there is a role for increasing the preload by giving IV fluids. Whenever there is chronic effusion, it is TB, uremia, and malignancy. And in constrictive versus tamponade, what is the difference? A prominent Y descent is a feature of constrictive pericarditis. Absent Y descent is the feature of tamponade. ఇది బాగా గుర్తుపెట్టుకోండి. ఫేవరెట్ రేపు అడుగుతాడు ఎగ్జామ్ లో నేను గుర్తొస్తా. రైట్? సో దట్ కంప్లీట్స్. ఎక్కడ ఉన్నామండి? 11th పేజీలో ఉన్నామా? ఓకే. ఉన్నదా ఓపిక? It is heavy on the mind, sir. 11th page ante you finished 1/5 of medicine.
అంతే కదా సార్ 50 pages.
ఉందా ఓపిక లేదా?
అప్ టు సార్. అంటే ఉన్నది. కొంచెం ఉన్నది.
ఓపిక ఉందా?
ఉన్నది.
లేకుంటే ఫెటిగ్ ఉంది?
ఫెటిగ్.
డోంట్ బి మోడెస్ట్.
బోత్ సార్, అంటే చేయాల్సిందే కానీ ఫెటిగ్.
That's called as living a married life. Good. Good to see 5 online classmates. We are very popular in doing last minute revision. ఏం లేదు, ఫెటిక్ వస్తే పండుకోవాలి, లేవాలి, కూర్చోవాలి, చదువుతూనే ఉండాలి, ఇక తప్పదు. ఇంత ఫాస్ట్ ఎక్కడైతుంది మెడిసిన్? ఎక్కడ కాదు. ఇవన్నీ షార్ట్ టాపిక్స్. నేను అందుకోసమే మధ్యాహ్నం 2 గంటలకల్లా వచ్చి పీక తింటా మిమ్మల్ని 8 వరకు. బీ ప్రిపేర్డ్ సైకలాజికల్లీ. ఇక్కడ మీకు వదిలేస్తే మీరు పూర్తి అయ్యారు, ఈ జన్మ కాదు. ఇప్పుడే మీరు ఇది లాస్ట్ అండ్ ఫైనల్. जिंदगी में कभी नहीं देखते. क्या बोलते? We don't see all this once more. Now, hypertrophic obstructive cardiomyopathy. What is the problem in this? Interventricular septum is enlarged. Hypertrophy, and anterior mitral valve leaflet will come and touch it, so that when blood flows from left atrium into left ventricle and from left ventricle it has to go into aorta, the left ventricular outflow tract is blocked by the touching between anterior mitral leaflet and hypertrophied interventricular septum. It is autosomal dominant. Beta myosin, heavy chain myosin binding protein C is the one which is mutated. And if you look histopathology, there is a myofibrillar disarray histopathologically. And most common cause of death is once more sudden cardiac death. So how will be the question in the exam? A football player while running suddenly collapse. Sudden cardiac death, only 2 causes. One is mitral valve prolapse, other is HOCM. And the most common presentation is shortness on exertion. Right? So why? Whenever you are exerting and running, then there is a decreased venous return to heart. Heart chambers become small in size. And that will cause more left ventricular outflow obstruction. And if the obstruction is there, the amount of the blood going into the root of aorta diminishes. From the root of aorta, there will be blood flow that will be going into coronaries.
Hmm.
That's the reason there'll be angina
Okay.
with nitrate-like drugs, which can decrease the venous return because they are venodilators.
Yes.
Nitrate-like drug. Normally, nitrates relieve the angina.
Yeah.
Yeah.
Nitrates lead to angina in
HOC.
HOCM.
So it's
ఎందుకంటే
combined.
నైట్రేట్ ఇస్తే vasodilation. Vasodilation ఉంటే decreased ventricular size. And that lead to
Worse.
touching more
Yeah.
and decreased output. Syncope, whenever the LVOT obstruction is there, the amount of the blood going into the cerebral circulation diminishes. That lead to syncope.
Yeah.
Okay.
And the carotid pulse typically in HOCM is bifid. There will be a spike and dome. Why spike? The moment left ventricle contracts, a little blood will flow spike. And once more, this obstruction will supervene. Further flow doesn't occur. So there is a fall. Spike and dome pattern. And the apex beat will be a double apical impulse. One beat will push and stop, and next once more the obstruction అయితే కదా అయిన కొంచెం టైం తీసుకుని it will overcome.
Okay.
It's a dynamic obstruction. Double apical impulse. ఈ రెండు గుర్తుపెట్టుకోండి.
Double.
Ah,
Bifid.
double apical bifid.
Okay.
Murmur is a systolic murmur, just like aortic stenosis.
Okay.
Systolic murmur at the left sternal border and Valsalva effect. If you do Valsalva, you are doing opposite to inspiration. Inspiration increases the venous return. Valsalva decreases the venous return. That will decrease the size of the ventricle, and that will increase the obstruction and increase the murmur. If you are doing squatting, then that will increase the venous return. Unlike standing, opposite to standing is squatting. And that will cause an increased filling and chamber size will increase.
Hence,
If you happen to give beta blocker will decrease the heart rate, and decreased heart rate will increase the diastolic filling time.
hence
That lead to increased filling, increased size of the chamber, and a decreased murmur is what you need to remember. Then ECG may, you find left ventricular hypertrophy, but Q waves are because of interventricular septal activity happening from
right.
left to right. Normally, right to left is your myocardial depolarization.
Yes.
Interventricular septal depolarization occurs from left to right. అందుకోసమే కదా Q waves are a feature only in left sided leads. ఎందుకంటే left sided leads ఇడిచిపెట్టిపోతుంది కదా
Right.
Okay.
ఏది
Okay.
your depolarization.
Yeah.
Right side leads ఉండద్దు. Any Q wave in right side lead is equal to MI, and a deep Q wave in left sided leads also
HOC.
is pathological. Very deep is
HOC.
the అర్థమైందిగా చూడండి మళ్ళీ ECG of septal అంత లెవెల్ ఇవ్వడలే. దట్ ఈస్ ఆల్ DM లెవెల్.
QAs.
అంటే డీప్ క్యూ వేవ్స్ ఆఫ్ HOCM ఇచ్చిండంటే ఎవరైనా ఆన్సర్ పెట్టిండంటే మనకి పేపర్ అవుట్ అయింది, లేకపోతే మురళీ భరద్వాజ్ స్టూడెంట్ అయి ఉండాలి. Right. Can online students can punch the voice loud and clear, doc? Now, అంటే ఆన్లో పెట్టేసి వెళ్ళిపోతారా స్టూడెంట్లు?
లేదు సార్, మేము లాగిన్ అవ్వాలి సార్ మెసేజ్ చేయాలంటే.
ఓ, అది లిమిటింగ్ ఫ్యాక్టర్.
లాగిన్ కాదు అంటే ఫోన్ నుంచి నేను యాక్సెస్ చేసిన లాగిన్ కావడం కొంచెం కష్టం.
ఓ, ఐ సీ.
యూట్యూబ్ లో లాగిన్ అవ్వాలి సార్.
YouTube లో login.
దెన్ ఐ కెన్ పుట్ అ మెసేజ్.
అందరు లాగిన్ అయి ఉంటారు కదా యూట్యూబ్ లో, ఉండరు? అన్ని సినిమాలు డౌన్లోడ్ చేసుకుని ఫ్లైట్ ఎక్కంగానే
ఇది ఓపెన్ చేయాలి కదా, ఫోన్ లో చూడడం ఈజీ.
Gotcha. Then what is the echo hallmark? You have to demonstrate that the symmetrical septal hypertrophy, that it is more than 15 mm. And what is another important feature? Systolic anterior motion
of the mitral
of the mitral valve
leaflet.
leaflet, systolila, anterior motion, SAM.
Systolic.
Then LVOT, left ventricular outflow tract together.
Yeah, pressure is high.
That is the one which is obstructed. That's the reason more than 30 millimeters mercury between the aortic pressure and the left ventricular pressure at the level of the LVOT, the gradient is diagnostic.
Okay.
So what is the first line treatment? Give the beta blockers. Beta blockers decrease the heart rate. Very important. Don't give diuretics. They decrease preload. Don't give nitrates, decrease preload. What are the high risk features? If there is a family history of sudden cardiac death.
Because it is autism.
I have one family of HOCM in Secunderabad.
Oh.
మొత్తం ఫ్యామిలీలో అందరికీ ఉంది HOCM. వాళ్ళ అబ్బాయి అమెరికాలో ఉంటాడు. ఫ్యామిలీ హిస్టరీ ఆఫ్ సడన్ కార్డియాక్ డెత్. If there is any syncope in HOCM, if the wall size is more than 30 mm, they're all indications.
Okay.
And what is the definitive treatment? You have to keep ICD,
Intracardiac device.
intracardiac device, defibrillator. Defibrillator, because arrhythmias will come, no? It will identify arrhythmia and then kick off. ICD, high risk వాళ్ళకి. Then how do you treat? You will do septal myomectomy. Alcohol boys tomorrow interventional cardiologist kada.
Yes.
Zoom, 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 you will go. And then using alcohol, you will ablate that hypertrophied septum. That's called a Moro procedure. All righty. ఒప్పుకుందా?
చేద్దాం.
అడుగుతా ఉంటాను నేను టు టెస్ట్ యువర్ కమిట్మెంట్ టు అవర్ టెర్రరిస్ట్ ఆర్గనైజేషన్.
ఇది రేపు చేద్దాం సార్. ఈసీజీ.
ఏమన్నది ఈసీజీ అవసరమా?
No, sir.
అస్సలు వీఆర్ అరే నేను కూర్చోబెట్టి మరి పాఠం చెప్పిన 2 సార్లు చెప్పిన ఈసీజీ నీకు. భరత్ అండ్ ఆల్ దట్ యూ రిమెంబర్ దట్ డే
Yes.
లాట్ ఆఫ్ స్టూడెంట్స్ కేమ్.
One of the most popular classes.
You will be in MD obstetrics, then he'll be going for his NEET PG. Huh? Our goal is to go top in INA CET and go to Sri Chitra Thirumal Institute of Medical Sciences for learning intervention. What do you say?
Yes.
I'm on that dream. Huh? అప్పుడు కూడా గోవా వాటికన్ పడుతుంది సెంటర్. Now, P wave atrial depolarization, QRS ventricular depolarization, P wave ventricular depolarization. PR interval normal value 0.2 seconds. PR interval is between P wave and QRS complex beginning,
Yes.
including P wave.
Yeah.
Intervals always include the wave. One small box is equal to 0.04 seconds. One large box is equal to 0.2 seconds because it has got 5 small boxes. కాబట్టి 0.2 అంటే ఒక పెద్ద డబ్బా is equal to beginning of P wave until the beginning of QRS, including P wave and
Beginning.
PR segment.
Yes.
QT interval prolonged in hypocalcemia. Hypercalcemia cause QT shortening.
Yeah.
Hypocalcemia cause QT lengthening. ST segment elevation may more than 1 mm in 2 contiguous leads. And ST depression is a feature of subendocardial ischemia. Ischemia ki sign is ST depression. And non-ST elevation MI also. Tall peaked T waves are typical feature of hyperkalemia. But they are asymmetrical
Asymmetric.
tall.
Okay.
Symmetrical tall is MI.
Yeah, hyperacute phase of it.
Hyperacute T waves of MI, which is the first to appear.
Yes.
U waves are a feature of hypokalemia and bradycardia. A wide QRS is a feature of ventricular
Bundle branch block.
fibrillation, ventricular tachycardia.
Yes.
Narrow QRS is a feature of
Supra-
supraventricular tachycardia, unless proven otherwise. Similarly, bundle branch blocks, LBBB, RBBB also will lead to wide QRS. But left bundle branch block, W shape in V1, M shape in V6. Right? Right bundle branch block, M shape in V1 and W shape in V6.
Marrow.
Opposite.
M shape in V1, W shape in V6 is
Right.
right.
Okay.
Marrow.
Reverse is that.
Yeah.
But both of them are wide QRS.
Yes.
And wide QRS లో ఇంకొక ఇండికేషన్ ఏంటి? Typically, you expect a small Q wave in the beginning of the QRS complex, normally only in the left-sided leads like V5, V6.
Okay.
Absence of that is an indication of LBBB.
Okay. Left-sided cup. Okay. Okay.
ఎందుకు అసలు లెఫ్ట్ సైడెడ్ లీడ్స్ లో వై డు యూ గెట్ స్మాల్ క్యూ వేవ్ బిఫోర్ ఆర్ఎస్? ఆర్ అనేది వెంట్రికులర్ డిపోలరైజేషన్, ఆర్ఎస్ అనేది ఇనీషియల్ గా సెప్టల్ యాక్టివిటీ విచ్ ఇస్ మూవింగ్ ఫ్రమ్ లెఫ్ట్ టు రైట్ విల్ సే టాటా గుడ్ బై టు లెఫ్ట్ సైడెడ్ లీడ్స్. స్మాల్
Q.
Q will be there.
Yeah.
But If the left bundle branch block is there, the septal activation will not be from
Left to right.
left to right. Rather, it will be
Right to
from the right to left. That's the reason the normal small Q wave that you see in the left sided leads won't appear anymore.
Okay, sir.
That's the reason absent
Q wave.
small Q wave.
Is in left bundle branch.
అది అర్థమైందా గుర్తుంటుందా అంత దూరం పోడు బట్ గుర్తుపెట్టుకో
Yeah, extra.
ఆర్బీబీబీ ఎల్బీబీబీ హౌ డు యూ రికగ్నైజ్ డెఫినెట్ గా రేపు పోయి చూసుకోండి పెథలాజికల్ క్యూ వేవ్ వెన్ డు యూ కాల్ ఎనీ క్యూ వేవ్ ఇన్ రైట్ సైడెడ్ లీడ్స్ ఈస్ pathological. In left sided you normally expect,
Yeah, just not.
but if it is more than 1 mm wide and more than 25% deep compared to the height of the R wave, then you call pathological Q wave. Low voltage QRS is a feature of obesity and pericardial effusion. Electrical alternance is a feature of pericardial effusion. Sawtooth pattern is a feature of atrial flutter and absent P wave. Irregular rhythm is atrial fibrillation. Delta wave is a feature of WPW syndrome. Osborne wave is a feature of hypothermia.
Yes, sir.
And prolonged PR interval is first degree heart block. ఇది చాలు 20. ఇంకా నేర్చుకోవాలంటే చాలా ఉంటాయి ఇంకొక 20 పాయింట్స్ గుంజొచ్చు దేఖలేంగే పైలా ఏ బచ్చగా
Pictures.
పిక్చర్లు పిక్చర్లు చూసుకుంటే సరిపోతుంది రైట్ ఇప్పుడు ఎక్కడైనా 14 పేజ్ 20 వరకు చదవాలి
సరే sir, చేసేస్తాను.
పట్టుబట్టాలి
Yeah.
మీరంతా యు ఆర్ ఆల్ 2.5 decades younger to me.
Yes.
Most common source of what? Pulmonary embolism
DVTs.
comes from the DVT.
Like
Prolonged immobilization is a risk factor, like sitting in the reading room and studying. What is the Virchow triad? You know.
stays.
What is the classic triad of PE? Hemoptysis, dyspnea, pleuritic chest pain. Why hemoptysis? Whenever embolus is blocking the pulmonary artery, pulmonary parenchyma will suffer from ischemic necrosis.
Okay, sir.
And lung is a organ with dual circulation. Dual circulation infarcts are all red infarcts, like your gut, etc. So that is the reason any infarction of the lung tissue will lead to hemorrhagic infarct, and that lead to hemoptysis. And overlying pleura become inflamed, leading to pleuritic chest pain along with dyspnea. The most common symptom is dyspnea. The most common sign is tachypnea. Sign is symptom veru.
Yeah.
And what is massive pulmonary embolism? S1, Q3, T3, but that is not most common. The most common ECG is sinus tachycardia.
Okay, just tachycardia.
Yeah.
Why sinus tachycardia? Because the moment pulmonary embolus is there, acute pulmonary hypertension is there, the right ventricle is unable to pump into the pulmonary artery. The moment the cardiac output is diminished, the heart will compensate by
Tachycardia.
tachycardia. So sinus tachycardia is the feature of
Commonest feature of pulmonary embolism.
pulmonary embolism on ECG. But most characteristic, like gold standard.
S1.
S1, Q3, T3. S means negative wala wave before R wave in lead 1. Q3, negative wala wave before ఇది after R, yes ante. Before R is Q, and T wave inversion in lead 3. Need to be remembered. And because a patient has tachypnea, hyperventilating, he will have respiratory alkalosis. D-dimer. It has got a very low specificity but high sensitivity. If you are clinically suspecting a dyspneic patient, if D-dimer is elevated significantly, it is sensitive very early.
Yes.
But there are 100 reasons for D-dimer to be positive. But the best initial test is CT pulmonary angiography. But that is not easy, my dear. To hold the breath for a pulmonary angio to picture to be taken, he is a tachypnic patient.
Also dyspnea.
Very difficult, but are they initial test? Again, you can clearly see by passing contrast the block.
Yeah.
Okay.
The gold standard is pulmonary angiography. The stomach sign Hunton's hump. Whenever there is an embolus, there is a decreased blood flow through the pulmonary vessel. That's the reason there is a focal oligemia
Decrease.
distal to the embolus. Mere X-ray uste bronchovascular markings lo, there will be oligemic lung fail.
Okay.
Then all that infarction of the lung that happen will lead to a wedge-shaped infarct that gives an opacity subpleurally, which is called Hampton's hump. Initial treatment is what? Low molecular weight heparin or unfractionated heparin. And definitive treatment is you need to give oral anticoagulants 3 to 6 months. If there is a massive pulmonary embolism, you need to do alteplase ke saath thrombolysis. That easy, my dear. Once more, because he has got a pulmonary hemorrhagic infarct. Sometimes they'll have pleural effusion. When you drain that, it will be showing blood, frankly. To such a person giving a thrombolytic, you should have balls.
Yes.
So you need to be courageous to take that step. Then another thing, you need to do, those who can't be given thrombolysis, you can do embolectomy. Nowadays, once more intervention, tuck through the vessel and remove the embolus. Or you put an IVC filter to prevent further embolism. So what is the Bell score? There's a score called Bell score. More than 6 is high probability of PA. Adi enti avsaram le. Bell's score is he's wo jaake kubbe mein kood rahe pulmonary embolism se. Well. Prevention of PA is early ambulation. Finish. Now, doctor, pulse. Ask the nurse, what is the bradycardia? Less than 60. Tachycardia more than 100. Lot of nurses don't know. Tachycardia commonly is due to anxiety, anemia, fever. Bradycardia is yogic BP in athletes and heart block. What is the pulse deficit? If the heart rate apex and radial pulse, if there is any difference in the rate, you call pulse deficit. Where do you find? If there is any atrial fibrillation,
Okay, sir.
then the heart rate doesn't translate into pulse rate. That's the reason you find the pulse deficit. Irregular pulse is atrial fibrillation. Regularly irregular is second degree heart block. Second degree heart block can be of 2 types. What are they? Mobitz type 1 and type 2. Where do you find Wenckebach phenomena? Where there is a serial prolongation of the PR interval before drop.
Type 1.
Type 1.
Type 2 is random.
Correct. And which is an indication for pacemaker?
Type 2.
Type 2. Sir.
Type 2.
Overall type 2.
Yeah.
Type 2. Because sudden
Drop.
announcements are not good.
Yeah.
Except for giving the ring to girl. So pulses alternates. Whenever LVF is there, there's an alternating strong and weak pulse called alternance. Paradoxes, more than 10 millimeters mercury difference between inspiration and expiration. So other than tamponade, where will you find pulse paradoxes? Severe bronchial asthma. What is anacrotic pulse? Typically, there is a dicrotic notch in the
Normal pulse.
but in aortic stenosis, there is absent. So slow rising, small volume, anacrotic pulse is the feature of aortic stenosis. What is Bispherians pulse? Double peak in systole. It can happen with AR plus AS or HOCM. What is the dicrotic pulse? Dicrotic pulse also has 2 peaks, but one is in systole, other is in diastole. Whereas Bispherians is both of them are in systole. Dicrotic pulse is a feature of the sepsis or any low cardiac output. In sepsis, there is a severe vasodilatation, decreased preload, leading to dicrotic pulse. What is water hammer pulse? It's a collapsing high volume pulse which is seen in AR and also PDA. What is bigeminal pulse? Whenever there are any premature ventricular complexes, there will be alternating strong
And weak.
alternates normal plus that premature PVC. Together is called bigeminal in premature ventricular complex. Any low volume pulse which is very weak in shock is steady. Wide pulse pressure in fever AR, PDA, very thyrotoxicosis is bounding pulse. Pulses ectardus is a low volume pulse with a delayed upstroke which is seen in severe aortic stenosis. Where do you feel the aortic stenosis murmur? Where will it radiate into? carotids. Then jerky bifid pulse is feature of spike and dome in HOCM. Unequal pulses are seen in coarctation, aortic dissection. Why aortic dissection? Subclavian arises from aortic.
Yeah.
So aortic dissection will diminish the supply to
Limbs.
left subclavian.
Yeah.
దాంతోటి లెఫ్ట్ కి పల్స్ ఉండదు, రైట్ కి పల్స్ ఉంటుంది. లెఫ్ట్ లో పల్స్ ఉండదు బికాస్ అయోటిక్ dilatation will lead to narrowing down of the orifice of the subclavian originating from aorta.
Okay, sir.
Similarly, Takayasu arthritis also typically is associated with pulseless disease
Yes.
with unequal pulses. Coarctation of aorta also. Suppose if it is originating before the origin of subclavian, then what will happen? Subclavian doesn't get enough blood. So it will be typically diminished. Left subclavian. Radiofemoral delay, coarctation of aorta. Absent peripheral pulses are the feature of acute limb ischemia. Easy. అంటే ఈ మొత్తం దాంట్లో మీకు 3-4 ఉంటాయిపా, అవి జర్ర కొంచెము యాద్ చేసుకుంటే రేపు మళ్ళీ పరీక్షలు గవే వస్తాయి. ఎటు బో. ద నెక్స్ట్ ఫేవరెట్ టాపిక్ ఆఫ్ ద ఎగ్జామినర్ ఎంత టైం అయిందన్నా? 1:05. 1 hour 15, 17 pages.
9 o'clock. Yeah.
9 అయిందా?
9 sir.
खत्म करेंगे.
Yeah.
20 into 20.
20 just.
Yeah.
No giving up.
Yeah.
Let's get the feeling of last minute preparation.
Bad.
Oh yeah.
Sir, they couldn't.
Yeah.
నన్నేం గుర్తులేవే?
It's just
They're finishing you.
they're not doing anything to you, sir, but they're around. Nadi, this is like insect bite.
Hmm?
Insect
Oh,
bite. And it's very itchy.
yeah.
ఎక్కడ కొట్టింది అడు. It's not mosquito. పోయిందా?
Yeah.
Keep it near you.
Oh. అన్ని గ్రూపులో వేసారు కదా వీళ్ళు. Somebody didn't receive. Okay. All righty. What's now? Okay. Now, doctor, digitalis. Digitalis is a positive inotropic agent. How does it act? Sodium, potassium, ATPase pump inhibitor, which will increase the intracellular calcium. It won't let the calcium go out. And that will increase the myocardial contractility because sarcoplasmic reticulum low calcium-induced calcium release. And that calcium will cause actin myosin to bind with each other. That is the underlying cause. Also, digitalis has got a vagomimetic effect. It will cause the vagus stimulate, and that will cause the AV node to get blocked, and that will slow down the heart rate. And that is the reason for which we use the digitalis in case of atrial fibrillation. Okay. For its vagomimetic activity to slow down the heart rate. Right? Now, what are the clinical uses of CHF? Symptomatic relief, but no mortality benefit, you give it or not. And it causes the control of the rate in case of AF with CHF. What is the therapeutic level? 0.5 to 2 nanograms per ml. What is the earliest feature of toxicity? Not GI, cardiac, but GI. anorexia, nausea, vomiting. And what is the visual symptom? Yellow vision, xanthopsia. Compulsory auditory రేపు ఎంట్రన్స్ లా మళ్ళీ ఇది చూసుకోండి. Scooped ST depression. ST depresses and scooped. That's called Salvador Dali's mustache of. He's a Spanish savage. The most dangerous toxicity is ventricular arrhythmia. And what leads to the digitalis toxicity, don't forget, hypokalemia, hypomagnesemia, and hypercalcemia. Inkoka rule. Hypokalemia predisposes to digitalis toxicity, but hyperkalemia is the consequence of digitalis toxicity. इसके वजह से digitalis toxicity आता है और digitalis toxicity के वजह से hyper आएगा. And what are the drugs that lead to digoxin toxicity? Quinidine, verapamil are the ones to need to remember. And what is the antidote for digitalis toxicity? Lidocaine, phenytoin for arrhythmias. And very important rule, doctor. Whenever there is a hyperkalemia, first thing that we give is giving calcium gluconate, then we give insulin plus glucose. Insulin will decrease the potassium levels, calcium will protect the heart from getting arrhythmias because of hyperkalemia. Common renal failure patients andarla hyperkalemia untadi. The only place where if there is hyperkalemia you don't give calcium is if that hyperkalemia is because of digoxin toxicity, because hyperkalemia itself predisposed to the worsening of the digoxin toxicity. Then we also give digoxin specific FAB fragments, anti-digoxin antibodies. FAB ante AB ante antibody ade heavy chain la untayi kada, antigen recognition ki antibody specificity ki antibody. What is the half life of digoxin? If the renal function is normal, it is 36 hours. Digoxin is excreted by the kidney, hence dose adjust in CKD. And if at all, the congestive heart failure can be of two kinds. What are they? Systolic dysfunction, diastolic, inability to fill. Systolic is inability to pump. And inability to pump is called HF or EF. Heart failure with reduced ejection fraction. Inability to get filled is called heart failure with preserved ejection fraction. HFPEF. There it is not useful. Digoxin. Only heart failure with reduced ejection fraction. Right? Now, what is the effect on AV block? If already AV block is there, this is causing further
AV block. Yeah.
vagomimetic effect on AV node, no?
Yeah.
It can worsen. Right? This is called digoxin bhaiya gurinchi. Then comes clubbing. Earliest sign of clubbing is there is a Lovibond angle between the nail bed and your this thing. Itla pedite significant untadi. Mana andar koncham untadi. Diamond shape untadi valli. That is loss of Lovibond angle less than 160. Loss of diamond shaped window. Sorry, ee diamond shape untadi. Undadu. Grade of clubbing. Fluctuation, beaking, drumstick, hypertrophic osteoarthropathy. Most common cause is bronchogenic carcinoma, lung disease. Most common cardiac cause is cyanotic congenital heart disease like tetralogy of Fallot. What are the 4 T's you remember about cyanotic heart disease? Total anomalous pulmonary venous circulation. T is stoph. Truncus arteriosus and tricuspid atresia. ఇందులో దేంట్లో మీకు ఒలిగిమిక్ లంగ్ ఫీల్డ్స్ ఉంటాయి, దేంట్లో మీకు పల్మోనరీ ప్లిథోరా ఉంటుంది, టాఫ్ ఉంటే పిఎస్ ఉంటుంది. సో నో బ్లడ్ ఈస్ గోయింగ్ ఇన్ టు లంగ్స్. దట్స్ రీజన్ ఇట్ ఈస్ ఒలిగిమిక్ లంగ్ ఫీల్డ్. Truncus arteriosus and TAPVC you have plethora. And tricuspid atresia, TOF lo oligemia. Then what are the respiratory causes of clubbing? Lung abscess, bronchiectasis and fibrosis. Cardiac causes, atrial myxoma, infective endocarditis, Similarly, GI, ulcerative colitis, Crohn's, cirrhosis, and biliary atresia. Endocrine, Graves' disease, thyroid, acropathy. Then, long period of time, there'll be painful swelling of the long bones, which is called hypertrophic obstructive cardiomyopathy. 2 causes for pseudo-clubbing. Psoriasis and systemic sclerosis. Unilateral clubbing. Any aneurysm, Pancoast tumor, hemiplegia, they cause unilateral. Reversible clubbing is very rare.
Yeah.
Among the lung cancers, most commonly, there are many variants, no?
Squamous.
Adenocarcinoma, squamous, and small cell. Small cell वाट बतकने बतकड़ू, जल्दी मेटास्टेस हो जाता, छोटू बहुत जल्दी भागेगा. Huh?
Yeah.
So surgery is never treatment in small cell. Chemotherapy is the treatment in small cell.
Yeah.
And he won't live until clubbing develops.
Yeah.
That's the reason most commonly it is the adenocarcinoma. And never you find the clubbing in COPD rule.
Okay.
But if COPD patient happen to develop clubbing, that means there is an underlying lung cancer, because same smoking lead to COPD and also lead to
Cancer.
clubbing in children
Cyanotic.
is due to lung abscess and cyanotic heart disease. Then TOF, TGA, Eisenmenger syndrome, they all cyanotic heart disease. ఇదండి ట్రీట్మెంట్. అయిపోయిందా? ఇంతకంటే ఏం అడగండి వాడు. కానీ ఇవి గట్టి గుర్తుపెట్టుకుంటే మిగతా ఏదైనా పెట్టదు. కోచింగ్ షుడ్ బి దిస్, ఐ థింక్. Why we don't do?
No, sir.
Why?
Coaching like this is after we take that elongated, elaborated medicine classes. Then it makes sense. Sir, itla batti cheyadam enta kashtam sir cheppandi.
Is it very difficult to memorize?
Because sir, you've taught him medicine. Then he is able to connect.
I taught you also, no? But oh, you suffer Alzheimer.
No, sir.
Granny has Alzheimer. Vitamin B12 deficiency. One of my students used to take everyday vitamin B12 tablet to improve memory. Some crazy ideas. Somebody took anxiolytic and went to exam and slept. Anxiety is a part of the game.
Yeah, and medical school, my classmates, they used to take this propranolol before practicals.
Yeah. You don't take such drugs before exam and nuptial night.
Yeah.
Huh? If you have anxiety, cry loudly after entering. Now, normal JVP. నీకు ఎక్కలేదా? Oh, baby. అంటే you are actually suffering from guilt conscious.
No, sir.
ఎందుకు నేను టైం అంతా వేస్ట్ చేశాను? అక్కడ చదువుకుంటే మురళి సార్ ఇన్నిసార్లు చెప్పారు కదా, ఒక్కసారైనా చదువుకుంటే బాగుండేది.
ఇది చేసేసి
పక్కింట్లో పిన్ని గారి పురుడు పోసుకున్నా, ముందు ఇంట్లో వాళ్ళ పిల్లికి పెద్ద మనిషి అయినా, you used to call up and go to.
You know that I can't make sense of whatever you're saying. That is too much of Telugu for me.
आगे वाले घर के बिल्ली को प्यूबर्टी हो गया तो भी आप पढ़ाई छोड़ के जाते. बाजू वाले
just saturate it with that. Saturate with that in case.
No saturated?
Yeah, sir.
Okay, good. Chalo. Then board meeting confirmed, maximum votes saturated. So thank you all for attending the session, Doctor. Tomorrow, but still
Yeah.
remarkable progress, right?